I'm Dr. Chris Landon. I'm still Director of Pediatrics at Ventura County Medical Center. I do run the Allergy Pulmonary Clinic and the Cystic Fibrosis Clinic here. I'm on the faculty at USC, at Children's Hospital Los Angeles, and in the Family Medicine faculty at UCLA. I've been here since 1989, so March of 2019 will be my 30th year here, and during that time we've been able to build a pediatric unit, a clinic, a pediatric intensive care unit, and we're working now on a Ronald McDonald House. So we're almost there. My Machu Picchu is almost constructed. I also do research for AbbVie, Gilead, Hillrom, Insmed, and PARI around patients with cystic fibrosis. As a clinician, I can see problems and then I approach them with investigator-initiated studies. One of which, just to wake everybody up, that will be coming up is called Naked, and it's a 3D sensor, and I can do BMI and so forth, and they are scanned from head to toe, and including a weight, because our problem is not obesity, but the other way around. This morning, I'm going to really concentrate on antimicrobial stewardship, which is a big push. So we have a very unique problem in cystic fibrosis, in that we have chronic bacteria. Basically, we have a colon for a lung, and so how can we optimize that kind of environment? So we have this airway microbiology that we're going to talk about, what the various pathogens do if they're doing anything. Dr. Van de Vanter, who I'll talk about later, gave a lecture. I think he had probably 3 glasses of wine. He told our microbiologists, I don't know why you're doing sensitivities, just give them antibiotics while it works, and when it stops working, give them a different one, which the world started spinning the other way for microbiology technicians. So we'll talk about what he was talking about. Infection management, how can we prevent the initiation? How can we control? And now when we walk in on patients and wearing masks, how are you communicating with them? How are you able to coordinate care when all they can see is your eyes? I was at, I have a friend who was in Rodeo Drive, and there was a woman from Saudi Arabia, and she was in front of the lipstick counter. And she goes, why is she in front of the lipstick counter? She's got the full-on burqa. Anyway, so that's all we have to communicate sometimes with our patients. And then long-term strategies, because these patients are living into their 60s and 70s now. So what's going to be that long-term impact of chronic antibiotics? One of the advantages we have is the CF Foundation Registry. There's some 84 pieces of data that go up on every patient 4 times a year. And with these, we get an idea about if we make a minor change somewhere, if a butterfly is stepped on, is there going to be a change in a hurricane somewhere in Patagonia? So is there other impacts? And so by following the registry, we can look at those other impacts. So just for microbiology, we have all these fields, and with that, is the resistance? What bacteria are down there? What are the major bacteria? And so we're able to follow over time what these prevalence of different microorganisms are. Now, I don't know if you know, but in the first quarter of this year, I wrote for $6 million worth of drugs for patients with cystic fibrosis in my clinic. So for $310,000 a year, there's a pill that you can take twice a day that prevents the flow of sodium and chloride from being interfered with, changing the environment down below. Now, if we take that, it's now down to H2. If you take a $310,000 a year drug and multiply it times 60 years, suddenly we've got a $22 million per patient cost. Now, I put this on the computer, and it's e to the -5, whatever. It becomes logarithmic when you multiply that times 30,000 patients. But what's happened is the prevalence has changed. So what happens is the first organism generally down there, and they have all the usual organisms that kids get, the pneumococcus, the Haemophilus influenza, and their hands are in their mouth. As a result, Staph aureus is the first bacteria down there. So with Staph, generally until about age 6 or so, that's our predominating organism. And then as Pseudomonas comes in, Pseudomonas is one of the most clever bacteria in terms of being able to change its gene, and it passes gene DNA back and forth. And what's happening is Staph aureus is sucking up all the iron in the environment, making it very difficult for Pseudomonas to grow. And then the Pseudomonas eventually figured that out, pierced the Staph aureus, and take over the underlying environment. So that's what you're seeing here is we have the Staph aureus as a predominating organism, and it becomes more and more prominent here. And what we have is our Pseudomonas aeruginosa, which is what we think of with cystic fibrosis, falling. So we have better measures against this, but this whole MRSA thing, if we were to culture everybody in this room, 40% of you at least have MRSA in your nose or on your skin from the laying on the gym mat to anything else. And then we also have the usual organisms, again, the Haemophilus influenza, with the aggressive treatment of Pseudomonas, Stenotrophomonas multifida, multiple drug-resistant Pseudomonas, the Chromobacter xylosoxidans. I feel like Harry Potter, something should appear in this chair when I say Chromobacter xylosoxidans, Burkholderia cepacia complex. So that we have all these bacteria, but that doesn't even begin to really touch the number of bacteria that are down there. So here we have an enormous industry oriented at killing Pseudomonas. We've got aerosolized Tobramycin, we have aerosolized aztreonam, we have experiments, which is where we get involved, aerosolizing ciprofloxacin, aerosolizing ceftazidime, aerosolizing Levofloxacin. So these companies are spending $60 million in trials per trial just to even get things going, and yet the total Pseudomonas is on its way down. In addition, azithromycin is a great anti-inflammatory. We think of it as, oh, here's your Z-Pack, you're in my urgent care, here's the Z-Pack, you're having another Z-Pack, oh, you have sinusitis, and it's a cold, but maybe there's an antiviral to Z-Pack. So the second use of it, which we've known for years and years from the Danes and Germans, is that that whole macrolide family is a good anti-inflammatory. If we take it Monday, Wednesday, Friday, and combine it with anti-pseudomonal therapy, we get much better lung function over a longer period of time. But what happens is now we have to worry about partially treated non-tuberculous mycobacteria. So every year we do non-tuberculous mycobacteria surveillance, and so the Mycobacterium avium complex, all these things come to the fore, so that we have to worry about it in terms of the anti-inflammatory we're giving crossing over and bringing us a resistant non-tuberculous mycobacteria. So this is just most of it's from those parrots and parakeets and so forth, so the Mycobacterium avium complex. But Mycobacterium abscessus, this stuff just melts your lung. It's a terrible thing. We're cutting out lung. And when you have a progressive lung disease and you start snipping at lung, it's a difficult process. So as people live longer and have been exposed to more bacteria and so forth, and we're looking at lung transplant ahead, if we seed that brand new transplanted lung and immune suppress, with some of these bacteria are not ones you want to have there. So how do we explain this change? So here we are, we're on the way down. Well, what we do, and we'll talk about, is we have these very aggressive strategies. So once Pseudomonas is down there, it tends not to go away. Now, if you sniff your shoe, if you are replacing your New Balance shoes every 2 weeks, to get the latest style and color and so forth, you're going to smell Pseudomonas. If you culture the forks in your at home, you're going to have Pseudomonas. It's in the spoons, it's in the sinks. Pseudomonas it loves water, and it loves the cystic fibrosis environment. As a consequence, it's relatively a benign bacteria. It's not like Pseudomonas sepsis in burns. It's a benign bacteria, but unfortunately the body wants to kill it. And in doing so, all those pyrogens and just the endogenous products of those white blood cells exploding, trying to kill the Pseudomonas is what causes the damage. It's not the Pseudomonas itself, it's the reaction against the Pseudomonas. So if I can get that Pseudomonas down to something manageable, so we have these very aggressive eradication measures, which we'll talk about. We have prophylactic measures, we have treatment that goes on for years and years and years and years, which means, of course, all of you who have, do I have to take 5 days of Bactrim, 10 days of amoxicillin, no, I'll take 3 days, I feel better. We've got years of this ahead of us. Now, what's happened is when I started, the median age of survival had gone from 2 to 12. That was in 1973-ish. It's now, we've got the median age of survival is over 40, and it's probably going to hit 60 in the next 5 years. So the problem is that all those people from 60 years ago didn't have the advantage of these $310,000 a year medications that are prolonging survival. So it's not that any of these problems are going to go away, but they are getting better. With our pediatric clinic, we just received a grant from the Cystic Fibrosis Foundation because more than half the patients that I take care of are adults. I don't do the fickle finger of fate exam. I breast examination, colonoscopy, osteoporosis. Oh my gosh. So when I needed a co-director, we brought in Dr. Preston Arndt, who's actually listening online. You can get this live, and we'll put this on our YouTube channel as well. So with Preston and our grant that we received from the CF Foundation, we are busy taking our adult patients and we'll be transitioning them to Santa Barbara. Preston will be going up to Santa Barbara. We'll still hospitalize here. The in-between visits will be here. But adults, you guys are just, all that pubic hair, I don't know what it is, but you're different. So as a pediatrician, I had to learn a lot about young adults over the years, the age 21s and the 25s, but now 28, 40-year-olds, this is now getting beyond my ken. And that's really what the CF Foundation understands. So we'll be undergoing incredible quality improvement initiatives, looking at our patients and the place we take care of them and the persons involved and improving that transition. So here's our problem. $310,000 a year does change the environment in there. So the movement of chloride. So there's the child whose brow tastes of salt, tastes of death. Is the German proverb. So if you went around and lick your children, the ones with CF do taste saltier. We have made diagnoses with it. Why is he so popular, the dog? But now we do newborn screening. So now most of what we have, we're discovering at birth. So you just gave birth to the Gerber baby, the perfect baby, that child that's on the label. And then you get a letter from the state of California saying, oh, your baby screened positive for cystic fibrosis. We'd like you to be seen at a local cystic fibrosis center. So people would have to drive down to Children's Hospital of San Andreas. They'd have to get a sweat chloride. So some 4 months later, 6 months later, they're into a team. The median age of initial referral before we started newborn screening was 18 months. 2 hospitalizations, and that's why way back when, if we go in the Wayback Machine, survival was age 2 years. So they'd be diagnosed at 18 months and be dead 6 months later. Well, now what we know, and the reason we have the adult clinic, is that their first diagnosis we are making at age 82. So we have a woman from Santa Barbara, very wealthy. She goes swimming in the ocean every day, 365 days a year. She was well nourished. She had one of the subtypes, and there's over 2,200 genes involved. So on the long arm of chromosome 7 at the 508th amino acid position, there's a deletion of phenylalanine. So that's your typical classical CF, is delta F508, delta F508. So 2 genes, 1 in 20 are carriers. So we have we have almost 20 people in the room. So one of you is a CF carrier. And probably there was some advantage in terms of cholera or fighting off TB, or there's something, hopefully, whoever threw that gene in. But there's all these subtypes. And we see so many patients from South America, from Central America, from Mexico, who have some consanguinity. These are small villages in the valleys in Oaxaca or whatever. So now we have multiple gene types. The ivacaftor will change that chloride environment down there, which changes the incidence of bacteria. You don't have that sweaty, awful smelling New Balance tennis shoe that you get. So with that, then how do we look down there? So when the way you guys throw out antibiotics without culture, well, that's fine. We're really trying antibiotic stewardship, and maybe we want to know if there's strep before you give penicillin to everybody via telemedicine for $30. We just, gosh, I don't know your immunization record. Oh, I don't know your history of drug allergy. Oh, it's 3 in the morning. Could you point your camera somewhere in the vague direction of your child? Oh, amoxicillin. Really? I wonder why CVS is investing in Teladoc there. Anyway, so we need to take a look. And so down in Australia, they said, hey, we have a doctor down in Long Beach who feels everyone should be bronchhed. The indication for bronchoscopy is you signed in. Well, Ellie Nussbaum, as we take a look at the people who've done this in a really good fashion, doing a posterior pharyngeal culture, it gives you as much information as doing a bronchoscopy. So that's not the tonsils, that's going straight back. So I've been bitten 2 or 3 times. I've been headbutted, kicked. So I really try to go over everything, spit on. I'm trying to think of all the things that happen. But we do need to get that culture. And we start as babies, because I need to know if at 2 months, at 6 months. And what happened was we've thrown out some of the genes on the gene screening. Hey, they really didn't end up having, even though they're in that same region on the 7th arm, on the long arm of the chromosome 7, it doesn't really seem to be disease. And some of those patients had Pseudomonas. Well, because you're burping up Pseudomonas all the time. You have an 8 amino acid chain protein called defensin that's just killing Pseudomonas all the time. Every time you burp, you go out to a Mexican restaurant, have too much tequila, too many sausages, whatever, you're burping up a little GERD, you've got Pseudomonas in the back of your throat. So we can also find it in normal people as well. So when we take a look down there, we'll get a predominating organism. We'll get one organism, maybe we'll get 2 organisms, and we'll be able to work out that sensitivities, and everything will be wonderful. But if you start looking with microsomal RNA, all of a sudden we have thousands of bacteria down there. And that was really Dr. Van Deventer's point, is it's not just one thing down there. You've got a whole microbiome. You have a whole intestinal flora, and that's what we tried to prevent. We got a grant with Yale to give babies live culture yogurt. Hey, if instead of that hand in their mouth, putting staph in there, how about put benign bacteria and let benign bacteria down there? Because their hands are in their diapers, no disrespect to those of you who don't have children, but their hands are in their diapers, and they're just putting everything in their mouth. So if we could replace that major microbiome down there with something benign, would that be helpful? 3 years later with the FDA, they said, oh, you're killing bacteria. No, we're not killing bacteria, because antibiosis means you're against life. We're using a prebiotic, we're using a probiotic to prevent infection. No, it's an antibiotic, you'll need $60 million worth of testing. No, and we went for 3 years, finally we gave the money back, and in Italy, they're taking a look at it. So here's all those bacteria down there, and do they have any just do that, I think. Come on, move forward. Down, sideways, anywhere. There we go. So what's down there? Oh, well, your common Prevotella species, Melanogenica, Denticola, aureus, all kinds of strep species, Salmonella, Actinomyces. So these are all sitting down there. But I thought it was just Pseudomonas. I thought it was just Staph aureus that's down there. And so when I treat, I'm treating Pseudomonas. I'm treating Staph aureus. No, I've got this very complex microbiome down there, and we didn't suspect it. So what happens is, with time, what we see is these polymicrobial communities, as they head towards pre-lung transplant, really become nasty bacteria. So at first we had the same thing all the kids get, Staph aureus, H. flu, all those ear infection bugs we're worried about, and skin and so forth. And then we get this dynamic polymicrobial community down there. And then we end up with these very, very pathogenic bacteria. So our friends Pseudomonas, Burkholderia cepacia, Achromobacter xylosoxidans, as they're heading towards a complete melting of their lung, down to 15% of lung function. So what can we do? Well, first we have to learn about what's down there. How about fungus and viruses? So we have a lot of problems with ABPA and with Aspergillus down there, and Aspergillus loves asthma mucus, loves CF mucus, and it's not always being fought off. It's just a great place to grow. But as they get an IgE response and horrendous asthma, they end up, we used to have just amphotericin B, for those, I don't know if you have to be old to remember amphotericin B, but now we've got all these nice PO antibiotics, voriconazole and so forth. We have one child who has basically a foot fungus in his lungs. I go, what are your feet doing? What are you, sucking at your tennis shoes? I mean, give me a break. But with voriconazole, we can keep him in control. So what's the interaction between these species and these subspecies? And are they just colonizers? Are we fighting them off? Though we know that Pseudomonas decreasing will decrease your Pseudomonas, but should we attack everything? And so what's that gut microbiome all about? So we know once people acquire Pseudomonas, lung function declines rapidly, that we have a $5,000 a month drug called Pulmozyme, and they tried it first only in people with lung function less than 33%. There was no change in lung function, but they felt better. Their quality of life was improved, and as a result, the FDA passed it. So this whole, we should talk to the patients is helpful. We know once they've acquired Pseudomonas quality of life, it's don't have the energy, they're depressed and so forth, increased risk of hospitalization, reduced survival, and then multiple drug resistant is also with worse outcomes. So what can we do? So they've followed with this EPIC trial. We know that there's more morbidity, but we also know that there's more morbidity with my friend MRSA. So I have a set of a family with 3 children with cystic fibrosis. The boys were sent to me because they had recurrent sinusitis. One was 16, the other was 12. And while they were intubated for their sinus surgery, Pseudomonas came out, and one of the physicians from Santa Paula had sat there 25 years ago, I guess. Yeah. And said, oh, ha, 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 Pseudomonas, ha, ha, ha. We'll send these healthy, starker teenage boys to see Dr. Landon, and we'll see if they have cystic fibrosis, ha, ha, ha. And of course, they both had CF. And if you ask them the question, well, how many times a day do you go poop? 6. You know, that's normal. Well, it's normal if you're pancreatic insufficient. They were taking in 4,000, 5,000 calories a day. Their mother liked making a big breakfast and so forth. And so when they came back, I said, oh, any other children in the family? Oh, yes, little Kristen. And Kristen's now, gosh, probably 28, maybe 30. She's had a baby. She's on my $310,000 a year drugs. Oh, but she doesn't have CF. She's too cute. She wraps her, you know, Daddy, give me your finger. So, or here's my finger. Wrap yourself around. How many times a day does she go poop? Oh, 6 times a day. So this family for Thanksgiving, what do? They have MRSA. Do I separate them? Can they be in the same car together? Can they eat a meal together as a family? So the father's a minister. So how can we prevent this transmission back and forth? Do I have them wear masks? I have a company in Boston who just called me yesterday, and they have a mask now that's clear in the center, so you can see the mouth. Because trying to communicate just with the eyes for this co-production of care, working with the patients, you come in and you look like you're in a hazmat suit, for heaven's sakes. How can we communicate with them? How can we work with them together as patients? So this whole morbidity with Methicillin-Resistant Staph aureus it really speeds up the decline. So if they're MRSA positive versus MRSA negative, even though they have Staph aureus, there's a more rapid decline in their survival and lung function. So we don't want them to have MRSA. We don't want them to have Pseudomonas. All these bacteria associated with chronic infection. So even the Haemophilus influenza and so forth, non-tuberculous mycobacteria, Aspergillus fumigatus. So that's our big Streptomonas multifida. Now, some of it, when you take chronic antibiotics, they're inhaling Tobramycin twice a day, 30 days out of the month, and they have a month off to supposedly the wild type Pseudomonas will regrow, and they'll go, oh, I don't know about Toby, and then boom, we hit them the next month to try and keep it down. Well, there are these bacteria, then other bacteria start to emerge, and that's what happens with the Streptomonas multifida. Is we don't know, is it pathogenic or not, and then this acquiring again with this chronic azithromycin of the non-tuberculous mycobacteria. So how do they do this? Again, incredible DNA just passing things back and forth. So when people fail eradication, and what we'll do is even if they're 2 weeks old, 6 weeks old, 6 years old, they go on oral ciprofloxacin, they go on inhaled tobramycin, we culture them before and after, and oftentimes I can get 2 and 3 years before they reacquire the bacteria. But they have very, very clever pump systems, beta-lactamases, they decrease the outer membrane permeability. They're just little warriors down there, and so no matter what we send at them. And then the other is what we were talking about earlier, is this whole susceptibility testing. What's the right methodology? We've got automated systems, we've got disk diffusion, we've got the usual things, broth microdilution. And then when we have multiple types of pseudo, which ones do we test? So you can see where my friend Dr. Van de Vanter, who is God to me anyway, after a couple of glasses of wine says, I don't know, the antibiotic stops working, give them something else. And all the susceptibility testing in the world is just, maybe it's not going to be helpful because those bugs are so smart, they're hiding down there. There's zombie bacteria that aren't undergoing, they're not dividing. They're just walking around, just waiting to be re-emerge. So we have lots of challenges. So what we see is basically modified therapy of lack of therapeutic response. We tried surveilling for multiple drug resistant. We send our cultures off and we get synergy testing and we do both antibiotics. Nah, didn't work. And then, well, this is pretty key, infection prevention control. So it'd be nice to know. So what you may see from time to time is two kids on the benches. They are 10 feet apart. And these are two young adults talking about going to college. They're not allowed within 10 feet of each other. But I want them to see their eyes. I want them to see their mouths. And we know we can prevent the cross-contamination with the Pseudomonas that they have by separating them by 10 feet. We've tried Zoom. We've tried telephone. People want eye to eye. My friends in South Africa and England, they'll fly here. They want to see me eye to eye. They go, you're fine. I like hearing your voice, but I just need to look at you every once in a while. So, okay, fine. Come by. Ventura's nice. View of the ocean. So what's happening is this international group, and that's coming in 2018 because antimicrobial stewardship is important. And as you can see, there's my friend Dutch Van de Vanter. He'll be in there. We had a room. There were 300 people in the room, and this is at the CF conference. And he goes, okay, I want to know how many of you put patients in the hospital, culture them, put them on IV antibiotics, and for a CF exacerbation. We all raised our hand. He goes, and how many of you know the double-blind placebo-controlled trial testing that shows that's effective? Well, there is none. We just do it because it makes sense. And we did it. We wrapped this is 1973, 77, wrapped the bottles in aluminum foil. We didn't know whether they're getting antibiotics or not. Nah, everybody got better anyway. So just sitting in a bed, not eating and doing their treatments, actually adhering to what's a known regimen, improves their pulmonary function, puts weight on. So all this concentration on antibiotics, maybe it's more the adherence and the persistence of adherence over time. So not just 30 days or until the next visit, it's that persistence of adherence to a regimen that makes a difference. So how can where's the source of all these pathogens? Well, patient to patient. So again, that's my kids 10 feet away. We can't have summer camps anymore. We don't do that. If I have a CF family day, I get one patient with CF and that's it. Acquisition from the healthcare environment. Oh my gosh, here's the most dangerous place in the universe is my tie. Rob Moffat, who's out there, we had a baby cough on his tie, cultured pure pneumococcus, age 6 weeks. I gave him a jar of slime at the house staff because someone who's that smart in keeping track of it, but eyeglasses, door handles, we're in a terrible place. We have a device that I'll be bringing back called Hygiena, where we do ATPase testing to see where the bacteria are. Now, if you have children in daycare, the most dangerous place in the world is that preschool slide. Oh, you have no idea what's there. I had a company come to me, Dr. Landon, we want to use UV light to sterilize iPhones, because everybody now we're going to build that up. It's like Listerine for bad breath. We're going to build a paranoia about your iPhone. And we're going to put it in gas station bathrooms. It must be horrible in there. No, the horrible place is every time you touch that gas pump. That's where the bacteria are, and they are horrendous in terms of passage. So acquisition from the natural environment is a problem as well. So how can we prevent that? Well, there's contact, direct person to person. So we put on the gowns, we get in our little hazmat suits and become just down to our little burqas of communication with our eyes. Droplets. So again, we've got the 3 to 6 feet, coughing, sneezing during a respiratory procedure like a pulmonary function test. So we need to pull them off into another room. But then our hand hygiene, which is of course we want. Contact the gowns and gloves, performing PFT safely, identifying any barriers to that happening. Oh, we ran out of gowns. Oh, I have to see the patient. And then for the family, oh my gosh, there they are. There's my three Gregs all sitting at Thanksgiving dinner. Are they washing their hands? Are they covering they're doing the vampire cape cough? Are they wearing a mask? And you'll see we have masks. We try and bring our patients up even through the physician elevator at times, especially during the winter, so we can keep them apart. We don't have them waiting in our waiting room. Avoid in-person socialization. So imagine being isolated. You're a woman and you can never be around other women. Wow. Man can't be around other men. Patient with a chronic illness can't be around other patients with your chronic illness. And then cleaning and disinfecting respiratory equipment. We have a $850 nebulization tool, and there's a $250 gold screen that's laser imprinted so that they can get their treatments down to 3 minutes, and they will bring it in. There will be stalactites on it, just hanging stuff. Oh, do you clean this every day? Oh, yes, doctor, I clean it every day. So getting people to have all these habits. So in terms of the infection control, though, it's effective. Beforehand, we're at the 30% passing, and so you can look at the DNA and the msRNA, so we know which bacteria are there. Even with MRSA, with good measures, we can decrease that passage. And then this is the early Pseudomonas eradication trials: Tobramycin plus placebo, Tobramycin plus Cipro, Tobramycin plus placebo twice a day for 28 repeated, or 28 days on, 56 days off, or cycling it. So how many stayed exacerbation-free? Culture-based therapy, cycled therapy. Well, doing it by culture really didn't make that much of a difference. The percent that remained Pseudomonas aeruginosa positive, who were 100% were eligible, they all had Pseudomonas, and there's 40%, and by week 10, week 70. So trying to pick out how long. Do you do it cycled? Do you do continuous? Do you just try and wipe it out? These are questions that are very expensive questions at $6,000 a month for a month of therapy. So then doing a Tobramycin plus azithromycin for early Pseudomonas, and didn't really make a difference. MRSA eradication protocols. So can we really do everything that you do? If you've had surgery here, you're scrubbing your body down for 2 days ahead of time. You're getting the chlorhexidine, everything to try and prevent those associated infections with surgery. And so we can, by day 28, eliminate carriage of MRSA, and it does improve their pulmonary function. We do not have an aerosolized form, though, for yet to maintain this. So this is, we'll use 30 days of Bactrim, but the question is, sometimes if there's just this Staph aureus is down there, and unless they're having an exacerbation, do we really need to wipe it out? It's different from having MRSA inside infection. So that whole hysteria we had, whatever it was, 10 years ago, with everybody's got to be cultured. We just assume everybody has MRSA on their skin now. And so we look for actual infection and invasive infection before we undergo aggressive treatment. So the questions remain then, can most patients adhere to this complex regimen of scrubbing and the bleach baths and all the crazy things that go along with that? Is it going to bring out resistance? Is there a benefit in the long term? Is without conclusive clinical benefit? Should we be doing it? How do we monitor it? And then this inhaled vancomycin is really what we're looking forward to, and we'll make it up. Our pharmacists will make it up. But is it as effective as our very expensive linezolid therapy? And linezolid, when we have a MRSA infection that is invasive, can be effective by itself. Is Tobramycin effective in chronic suppression? Well, we want to inhibit it with this every other month, as we're talking about. 1 month on, 1 month off. Can we enhance the post-antibiotic effects? So you end up with this little up and down. Oh, on the drug, bam, good hit. Oh, start to fall apart. Oh, okay, here, start to fall apart. Oh. But this line, it continues to show that downhill progression. So it's helpful. It certainly beats the holy heck out of what we had, which was, again, survival to age 19. How about inhaled aztreonam? So with that, can we see the same kind of effect? And that's basically what we saw, is that we had a reduced need for additional antibiotics, well, placebo period, follow-up, median, so when did they start requiring antibiotics? Somewhere around 3 months out. So prophylaxis seems to be helpful, controlling infection helpful. The thing is that all that microbiome down there, as it turns out, there's Fusobacterium, Staph aureus down there as well. There's some people who just don't respond very well to AZLI. And so we have to, it's not just a matter of susceptibility, it's looking at that entire microbiome. It's not just that one bacteria. Then the addition of the AZLI, I happen to know Alex Durchak, who was, at the time was head of research. And what's happened is when you have a $310,000 a year drug, and you have a company that pays its CEO $42 million a year, a company called Vertex, they suck up every patient in their clinical trials. He tried to fill a trial looking at AZLI, alternating antibiotics with Tobramycin and as Aerosolized as Trinam, and they couldn't meet the change in pulmonary function. They couldn't meet the primary protocol because the study was underpowered. They 90 of 250 planned participants. So we're still stuck on that Dutch Van de Vander. Well, just do what works, keep doing that until it stops working, then do something else. We've participated in the Levofloxacin study, so there's a concept when you test drugs of non-inferiority, started with penicillin, and if it's at least as good as penicillin, it's great. It's not that you have to look for a drug that's better, you just have to be no worse than what came before. So what we've seen is this gradual, in terms of research, diminution in terms of finding new, more effective antibiotics. So when the levofloxacin, the time to next exacerbation, well, they got less Pseudomonas, they got fewer hospitalizations. You ended up being able to taste things. So as you inhale this stuff, you're putting more and more spicy things, desperately trying to taste what it is that you're eating. But in terms of this impact on infection, these are bad bacteria. And when you have them, you don't get back to baseline FEV1. You persistently go downhill. So you see we have toxoplasmosis bacterium. We put patients in, and we use a pulmonary exacerbation score. If you have had a cold in the last 2 weeks, you get a point. You have a little fever, fine, 100.5, we don't care. You bring up more mucus, you feel a little tired, a little short of breath, you bring up a little bit thicker mucus, you missed a day in the last couple of weeks of school in the hospital. Now that's a $60,000 hospitalization for 14 days. Do we want to get rid of them? Gosh, my ward's full and they look better. It's day 5, I want to send them home. Well, the other parts of that hospitalization having to do with adherence, with the airway clearance, with the nutrition, are all as important, if not more important, than the IV antibiotics. So how do we do this? We know we've tried to decrease the Pseudomonas, and if there's no change in density, and so a lot of our studies will be counting Pseudomonas. How about this polymicrobial infection? We've got probably 2,200 bacteria down there. Are they talking to each other? They're touching each other. They're forming these alginates. They're zombie bacteria surrounded with thick biofilm slime. So how do we kill them? So here's our microbiomes, and so these are just 2 different patients taking a look at the diversity of their microbiome and how it changes with treatment. So they decrease the predominating bacteria, but then the other bacteria just come to the fore. And do they have anything to do with lung function? And we still don't know that. So we've tried to really standardize the treatment. So we don't have enough evidence that there's an optimal treatment duration. Is it 5 days, 7 days, 10 days, 14 days? We know by day 21 you're well beyond. In fact, 14 days is probably where your maximal effect is. Maybe you get another day or 2, but then you're going to get infected by Mrs. Sada's poly drug-resistant Klebsiella or whatever. So if we can evaluate current physician practices and patient outcomes, so not make it so random. They looked at children over the age of 12, and mean duration of IV antibiotics, 15.9 days. Mean duration of percent expected improvement. So we do pulmonary functions day 1. and day 5 and day 10. So I need that 9% improvement. I need them to return to baseline, and they're not going to. Every time they're losing, it might just be 1 or 2%, but when you start multiplying that times 10 and 20 and now 30 and 40 and 50 and 60 years, you end up with no lung left whatsoever. So lung function recovery, well, here's admission, day 7, there's the end of IVs, and there's day 28. So once we stop that IV therapy, we get that regression again. So how long should we be treating? Are we going to be able to get back to baseline function? We have a family who actually ended up in Child Protective Services. The mother had gone to Curandero, and they had a bunch of, I'm sure, lead-containing things that beat the holy heck out of what we had. Because of that lack of cultural understanding, it was much better that this family was followed by Child Protective Services. Well, I don't know all the time that what we do is exactly right, but the hospitalization was helpful. She's just back. The child has lost 10% of his lung function. He's lost 10% of his body weight. Time to go back in the hospital. No. Ooh, we got you out of Child Protective Services. ICE will come straight to your house if your children are taken away and you're going to be leaving this country. No. So we're going to try and maximize our outpatient therapy, but they're going to need to come back in the hospital, recover function. So again, here's our antibiotic treatment duration, use of steroids. So on long-term study, use of steroids probably not helpful unless there's evidence of asthma as well, of reversible bronchospasm. So early responders, 10 versus 14 days, 14 versus 21 days. How long does it take for that pulmonary function to return? So, yes, sir.
Can I go back to the last slide real quick?
Please.
Okay, so in this situation, you got the red circle around the antibiotic treatment duration and the high priority 73%. Is that a proxy for being in the hospital and forcing adherence, or are some of these patients getting IV PICC lines and home antibiotic therapy?
Yeah, so with the insurance companies, the University of Utah did this study. It really shows that inpatient is better than outpatient.
To me, it feels like the forced adherence is a much bigger piece than the antibiotics obviously are important, but you put the PICC line in and send them home and they go back to doing their best therapy once a day. I'm guessing that they fall off. They don't get that same recovery of FEV1 as doing it 4 times a day in the hospital. That's what we're trying to show here, is that early discharge. I don't care what the insurance companies are saying, that early discharge is not helpful. We put Bluetooth in the vest machine, so I can now see whether or not that family in Oxnard is using it, and they are adhering to the vest. Or they're putting around their dog or a chair or something, but I know that vest is being given twice a day for the proper duration of treatment. Okay, I have 11 slides to go and 5 minutes, so we're cooking. Okay, so the non-tuberculous mycobacteria, really accelerates the progression of disease. Oftentimes it's indolent, transient, so do we treat it, do we not treat it? And so when we have this smear from the same species, how aggressive do we need to be? Well, if they're having additional symptoms and they're having fever, night sweats, weight loss, and the radiographic features really look, then we also need to make sure we don't have ABPA. So we have this allergic bronchopulmonary aspergillosis down there. Is sinuses, are they being treated properly? With the new drugs, by the way, this $310,000 ivacaftor and lumacaftor and so forth, the patients, it's like playing Mario Brothers. Their entire every cell in their body is affected by these drugs. And when I talk to them, they go, Dr. Landon, yes, I felt, imagine standing in a green field by a white picket fence, staring up into a blue sky. The farmer comes along and shoves a pitchfork through your head. So it affects the sinuses are very much a mucus-producing organ. The lungs, Dr. Landon, have you ever laid down and had a truck run over your chest? Because that's what it feels like. Severe vomiting. So it's affecting that mucus-producing intestine. So once they get beyond 14 days, the whole thing changes. The whole game changes. Those feelings go away. But getting them through that time. So the sinus disease, if they've had recent sinus surgery, we try to avoid the use of that particular drug. But co-infection is it not the non-tuberculous mycobacteria? What's happening with Staph aureus? Are they actually doing their airway clearance? Is there reactive airway disease down there as part of their morbidity? So what are we trying to figure out? There's something called TIP, which is an inhaled powder of Tobramycin. Very easy to use because, the adherence problems, it takes so long to use things. You inhale 8 capsules twice a day. First time I used it, this entire room looked like a cocaine factory had been exploded. There was white powder everywhere. It was horrendous. So we had a film crew come in from the company. They flew them in from England to go over how to instruct people on how to go down, how to sip it properly, how to do it in their native language. And they'll be flying back again to repeat that because the European Medical Agency said, we need to know that it's going down. Because here's our thing, is patients go, hey, I prefer a shorter treatment time, 10 versus 30 minutes. I prefer BID to TID meds. Airway clearance therapy, I don't have enough time in my day. I can't be bothered. So we have a program now in Montana called Attain Health, and by Zoom, they'll come to your house by Zoom. They do 2 hours on muscle training. They have a very aggressive nutrition program. The people who are the most compliant with it are not my teenagers. They'll go once or twice and then hip hop dancing or whatever his teenagers do now. They stop attending. Pre-transplant, you're looking at death's door, they're on it. They go, we hate being here. We hate sitting in this group. I hate seeing that guy from England. We've prevented 3 lung transplants from having to occur because they've almost doubled their FEV1 with proper compliance. So this treatment burden is awful. Once daily treatment, taken about 0.8 times a day. BID or TID, 1.4 times, so 3 times a day. Maybe they take half of it. Better adherence with inhaled treatment in the fall, winter, and weekends. We did put a Bluetooth in the delivery mechanism, showed without a doubt that the medication Pulmozyme caused you to go in the hospital. Because the only time people started using it was when they're feeling sick. Oh yeah, I didn't use, I can see, it's clear. You didn't use it July, August, September. October, you started using it 2 weeks later in the hospital. So there's liars, damn liars, and statisticians, but the use of medications is affected by that. And then 26% more patients, 29, would believe they would take meds if it took 5 minutes instead of 30. I have a 3-minute delivery device. They take it once a day. And they're supposed to take it 3 times a day. It takes 3 minutes. So as we change adherence, we used motivational interviewing. Now that I could follow them at home, had someone call them up, say, oh, I saw you used it on Monday. That's great. Could you try Monday, Wednesday, Friday? Oh, I see you did Monday, Wednesday, Friday. Could you try twice a day, Monday, Wednesday, Friday? Oh, I see you did Monday, Wednesday, Friday, twice a day. I see you called Dr. Landon, or you text Dr. Landon with pictures of your midnight snack. You could take it at midnight. Oh, now I've got 3 times a day, 5 days a week. Oh my gosh. And prevented them from going back in the hospital. Now, getting that behavior to persist rather than being annoyed by these frequent hospitalizations. So 108 minutes a day. What do you do for 108 minutes a day besides your smartphone? Probably nothing else in the world. So they're spending that much time on treatments. Adherence rate, 31 to 53%. Oh yeah, 2 out of 3, yeah, I skip treatments. Yeah, it's too much. And if you don't, more rapid disease, more school and work absence, increased risk of hospitalization, increased outpatient costs. So this is a major problem. And so what we're working on now is a co-production of care, and that's part of our grant from the CF Foundation. And that is that when they come in, it needs to be a triptych. It needs to be Hieronymus Bosch's Earth, Heaven, and Hell. And they need to come to you and tell you ahead of time what's important to them. Now, one of our patients, what's important to me is my uncle has prostate cancer. What do I know about where to send uncles with prostate cancer? And that's what we did. We found the doctor, we found the treatment regimen, we followed them up, and their adherence to the rest of their life improved. So it needs to be important to them. The middle is I need information. I need to know BMI over time. I need to know the pulmonary function over time. And then the last part, this co-production of care, is to come up with a program with them to change this adherence in whatever way we can, whatever it takes to do that. So education, appointment tracking, we did, I think you heard last year, we had messages on the phone 3 times a week. The house staff was involved. 2 of them dropped out the first day. You know, I don't want to get messages on my phone about cystic fibrosis. I go, it's 12 messages or 16 messages over 4 weeks. No, there were little surveys to answer. So even getting our house staff to cooperate with instant messaging. So we're going to keep working on different approaches to improve adherence and have that adherence persist. But with the kind of intervention we're about to do, appointment tracking, reminders, if I can get them in, increasing the number of visits, we know that we can improve their health care. So we're comparing ourselves against every other hospital, and 10 years ago, we were at the bottom 10 percentile for babies weighed under the age of 2. And so, great, I hear about a year later at this report. So the next year, with intervention, we had the fattest babies under age 2 in the United States of America. So by paying attention, by undergoing rapid cycles of improvement, plan, do, study, act, having an aim, that's what we'll be working on, is having a self-assessment, what's our problems, and how can we get a step ahead. So in summary, I hope you feel now that it's not just Pseudomonas down there, not just Staph aureus down there. It's a complex environment, that balance down there, we're not certain exactly what's going on, but we do know that once acquisition of Pseudomonas occurs, there's decrease in more morbidity and mortality, MRSA, more morbidity and mortality, non-tuberculous mycobacteria, and that we still are studying the best strategies to eliminate them. Susceptibility testing, probably not all that helpful. Certainly it's a wide clinical practice and makes us focus. But what's more important is the infection control, with the most dangerous person probably being that healthcare team member. So we're eradicating. We don't know how to eradicate MRSA quite yet. The treatment of exacerbations, how long should we treat? Still optimizing that as to what we look for. Once we have those more virulent pathogens down there, especially towards the end of life, when there's rather than a rich polymicrobial environment, it gets to be 2 or 3 different bacteria, things are worse. And so if we can just target all the factors and make sure they're important to the patients and their families so that they adhere. Thank you.
I missed what this new $300,000 a year medical.
Oh, yes.
What does it do?
I'm sorry you didn't invest in Vertex probably about 3 years ago. So what it does is we have on the long arm of chromosome 7, we have this deletion of phenylalanine, 508th amino acid position. So it's wound out in your DNA. In your DNA, there's a cystic fibrosis transmembrane conductance regulating factor. And so there's once that factor is made, there's a nuclear binding domain 1 and nuclear binding domain 2, and it brings them together. It then has to get to the surface of the cell, open up, and it's like a colander. And if that colander for straining spaghetti, all the holes are covered, you can't strain your spaghetti. It opens up the holes to make chloride go back and forth normally. So the environment here has a more normal, less friendly place for bacteria to grow. So your defensin can fight off bacteria normally because there's a normal concentration of chloride. So there are different genes, the G551D at 501st amino acid position, the deletion of guanine, Kalydeco, miracle drug. There's only 1,200 patients in the world with this particular drug. 248 of them are in Ireland. Ireland refused to pay for the drug. They go, no, we're not paying for it.
So does this cure the disease or prolong survival?
It prolongs survival. So you know, I come from the era, I was very happy. Some of the things I did, I got people, by changing their habits, to get people, the patients live from 19 to 21.
How long has this been around?
So the new therapy for using at age 2 to 12 is last week. The therapy in Kalydeco is about 5 years old. The girl
people have been living longer without this stuff.
Right.
With all these other things you've been describing.
Yep. So now
maybe it'll help, but maybe it won't.
So that gets to be that's the question on him. I flew to Dublin because this G551D, I had a little girl, 13 years old, came into my clinic wearing a Misfits t-shirt. She had black fingernails. She'd been removed from the house because her father had threatened the house staff at Children's Hospital Los Angeles, said, "I'm going to kill you." Now, evidently that's not allowed. And so they had, he had his own code. We have code silver. They had code, and I won't mention his name. SWAT teams would appear in the hospital. So they sent him to us. Thank you. So she had G551D. We sent her to Stanford. She went on the drug. her pulmonary function improved 20%. She came down here. We got her on the drug at age 13. Pulmonary function improved. Then she ended in the hospital. And CCS in Los Angeles is going, how's she in that hospital? You promised us for $310,000 a year that she was at Cedar, so it's $100,000 instead of $60,000. But that would go away. Well, people get the flu. 3 months later, she's back in the hospital. What the heck? They called me up again. They said, Dr. Landon, no, we're not going to continue to pay for this drug. Okay, let me do a home visit. I went home to her house. She's 13 years old. She had $20,000 worth of pills under her bed. So the bottle was going down. So Dad was being very carefully monitored. I have to tell you, he's giving them to her, and she's tossing the bed. So because she's wearing a Misfits T-shirt, I know Doyle, who is in the Misfits. I remember seeing them. He signed a CD to her, and it was, "I'm going to have sex with your sister in a cemetery." I go, maybe I'm not going to give her that CD. And he had a picture of himself that said, "Take your medicine, beast mode, Doyle." And she's taken it ever since. And so she's not been back in the hospital in 5 years. So the medications are very effective in terms of that time to next exacerbation. But it's going to take $310,000 a year. So if it's $60,000, it makes sense. That I can sell. They have these different criteria. There's quality adjusted life years, disability adjusted life years. So if I can get people to a time when they can give back to society by working, the governments in Europe and Canada, that's who I'm fighting with now, will pay $60,000 a year. They see that. They'd even see $100,000. 120, Dr. Landon. What's wrong with you Americans? Why are you paying the CEO $43 million? Why are we having to pay that? Vertex came down to about 150 in Dublin after, but the rest of the world can't. Sorry, the rest of the world can't know that. So that price has to come down.
So where's it made?
It's made here in America. I think Dr. Reddy.
Countries can get it for a fraction of the price.
No, they can't.
That's all they pay.
That's what they'll pay. They say, nope, you can die. These patients can die. They're not there. We don't care. So they get an extra 10 years of life. Fine. When it comes down to what we understand our healthcare system needs, which is we will pay for a quality adjusted life year, for disability adjusted life year, for a quality day, we will pay $60,000. We'll stretch it to 100 because we're a loving society. Here in America, it's approved by the FDA.
Is this a subset of cystic fibrosis?
Yes, so the G551D is a subset. The Delta F508, Delta F508 is another subset, and then there's some subgenes in there where the medications are effective.
Subset.
Yes, right.
Did you say how it works? Sorry, I heard you describe that.
So
they just add it back in as a fixed translation.
So the one that's out now, lumicaftor plus avacaftor, that makes people puke their guts out and feel like a truck's running over their chest and does two things. It has the CFTR as it comes off is damaged, and so the Golgi body apparatus says get rid of that. So it's like you're inside a Wells Fargo stagecoach. So it helps you to get to the surface, and then allows it to open up and allow that normal passage of chloride. Right. So it thins out the mucus. Yes, makes it
better than
yeah. So yeah, your little cilia are just stuck in this thick, god awful alginate, and so now they can move more normal.
Yeah. This works better.
Yeah, but I've got 2,200 CF genes, and so we had up in Santa Barbara, we have again patients being diagnosed for the first time at age 82. They have Pseudomonas. Turns out they're sweat chloride positive.
Hypertonic saline, swimming.
Well, that's and exercising and doing all the other things. Age 55, okay. Age 45, so okay, how? So their disease was later in onset. They were able to fight things off longer. My kids at birth, who have those same genes as these guys who are first diagnosed age 55, do we invest $21 million to get them from? That's that whole European disability life adjusted year quality. So at what point do you start spending money? Or could the CF Foundation go, yeah, 60,000, will Vertex bring the price down? Dr. Reddy in India, start making this stuff. Come on. Make it for $5 a pill instead of $200 a pill. And swim in the ocean. Daily, exactly. There we go. Yes, exactly. All right. I'm happy to take more questions. We'll end it here. Thank you.
Let me give them hypertonic saline.
How do we give
How do
it?
you administer hypertonics?
We use a PARI LC jet nebulizer. So we use PARI LC jet nebulizer. So we use 3% and 7%. People tolerate 3. And what we do is we put albuterol in with it because it causes bronchospasm about 10 minutes out. You give them the albuterol and the hypertonics at the same time. The albuterol is kicking in just as the hyperreactivity kicks in. So it's effective, getting people to adhere to these things and persist in their adherence. That's really that's the question. So if you had 60 years, well, just when you go to the dentist, you floss every day, right? Yeah, that day, maybe the day before, or if I have a rotten tooth and I had a hunk of steak stuck in there, I've been flossing 15 times a day. So, yeah. Okay, thank you.